congregate settings. And Dr. Wasserman, please add in at any point in time. It was something that came about around March, the ending of March, where Dr. Wasserman and I were invited to a meeting with the Hawaii Air National Guard out at the out at the National Guard buildings at Diamond Head. And the purpose of that meeting was really to look at a relationship or collaboration partnership with Hawaii Air National Guard. And one of the subjects that came about was congregate settings, and are we reaching out to congregate settings? How can we best help congregate settings to be able to prevent acquiring or spreading of the SARS-CoV-2 COVID-2 virus? So out of that meeting grew this primary prevention for congregate settings project. So next slide, please. And so the purpose of the project was to provide the purpose of the primary prevention project was really intended to provide primary prevention education to congregate settings to prevent the acquisition or transmission of SARS-CoV-2 virus. We were looking at homeless shelters, smaller group homes within the community settings. We were not looking, or what we did not do was we did not contact hospitals or skilled nursing facilities or assisted living facilities. We were looking at the smaller homes within the communities that housed a few people within their homes or within the community. We ran the pilot project for about a week in April, and only in 2 areas of where the public health nurses with the Hawaii Department of Health covered. So our coverage area for this pilot project ran from the west end of Fort Shafter to Sunset, and then majority of Central Oahu, and from Waipahu to Kaena Point. So next slide. Thank you. So this is just a quick breakdown of the pilot of what we did. And the types of facilities that were contacted during this pilot project. And so as you can see, majority of them were adult residential care homes, either Arch 1 or Arch 2. We did contact a few developmental disabilities, domiciliary type homes. In the mix was some of the mental health homes within our communities, independent living facilities where there were more senior residential, drug, alcohol, some for youth services, and homeless. Next slide, please. And okay, so one of the questions, so it was a series of questions that we asked, and one of the questions asked was, does your facility allow visitors? And out of the 60, 22% said yes, they did allow visitors. And what we tried to do was make it more progressional as far as the questions, like, okay, if you're allowing visitors, do you do screening? And if so, what type of screening are you performing? And so what you see here is some of the responses that we received from the various types of facilities as to how they screened, if they implemented some type of screening. One of the challenges that we found, and this is particular to independent living facilities or where more senior housing occurred, was that they were not able to regulate visitors. And so they allowed an unlimited number of visitors to enter the facility daily. And so public health nurses who were making these calls and conducting these surveys did their best to provide that education to the property or the facility operations manager as to how they can prevent, like, again, that transmission or acquiring of COVID-19. And so little snippets here, posting signage, posters to encourage visitors not to enter, limiting the number of non-essential visitors, because at the senior living facilities, what they were seeing was they had essential visitors, which were considered those that were there for health, well-being, or safety. And they also had family members coming into all during the same day. And then looking at this from a PPE standpoint, where a lot of our facilities were asking, do we need PPE? How do we manage this? But just at that time when this was going on, cloth face masks were just being introduced by our our mayor, getting them to resident and visitor to use cloth face masks during those visits. Next slide, please. The next series of questions that we asked actually inquired about the social distancing measures that were implemented. And as you can see here, they did a lot, the facilities did pretty well with the social distancing measures. What we found was the bathroom and bathing one person at a time because of the privacy issues for the homes. It was something that was easily implemented for them. Even transportation, some of our homeless facilities actually stopped transporting people during this time. Some of the challenges that we saw with this, and it was really with the homeless facility, not necessarily arch facilities, was the use or the it was multi-stall bathroom and bathing facilities where there were partitions between the stalls, and finding out that bathing schedules were not being utilized, and facilities did not consistently implement the 6 feet social distancing during mealtime and sleeping. What some of the responses that we got from arch care homes, um, from homeless shelters, including DD domiciliary homes, was that they were using a range. So yeah, we keep them about 4 to 6 feet apart. And so we provided more education to that one point in time, that education, if they're sharing rooms, head to toe configurations when you're sleeping, if they're able to utilize barriers between beds, if at all possible, um, if they're using multi-stall bathrooms or showers to clean more often, try to schedule bathing times, and then looking at how they could actually stagger the meal times to promote social distancing. And I will say that the arch care homes were they were pretty good about it. And I was like, yay, they're doing a good job. Is that they had their residents either eat in their room or at the table. They put people 6 feet apart, or they utilized outside spaces where people could keep that social distancing during meal times, but also feeling like they're still part of a group and not totally separating everyone. So next slide, please. So infection control was the next series of questions that we asked. And here we have the breakdown on the right of the types of the number of facilities and how often they were cleaning. Um, What we found is that 16 facilities were not real specific with us with their frequency. Um, 3 facilities really 3 times a day, and I was like, wow, that's really good. Majority of the facilities were disinfecting was done at least once a day. But more than 65% of the 60 that were included in the pilot project, as far as completed the surveys, they had signage posted or posters to encourage that actual infection control measures with hand washing, covering cough, um, coughing into elbow, staying at home when sick. One of the challenges that we found were that the terms disinfecting and cleaning are used synonymously, although they do have different meanings, and that the preparation of that commercial bleach varied, and staff did not know if solution served as a disinfectant. And I learned yesterday from Justin Lamb, who will speak a little bit later, as to why that may have been one of the gaps that was going on, and it has to do with part of processes on washing dishes, cleaning dishes. Difficulties with attaining items needed for cleaning and disinfecting. The facilities that we called, they had their budgeting for cleaning, disinfecting supplies comes out from their actual home. They have no grant. They have no means of getting reimbursed. Um, And so they needed to go out and go get these supplies themselves for the disinfecting and the cleaning. And basically, they were coming up short when they were doing their shopping, their usual shopping. So that became a challenge for the facilities. And so what we tried to do best as can was provide that appropriate commercial bleach to water ratio to use as a disinfectant for their surfaces to get using CDC guidelines. And then looking and taking it a step further that because we're actually looking at disinfecting for COVID, that they are using the appropriate equipment to, while they're cleaning and disinfecting. Next slide, please. The next series of questions actually talked about COVID-19 planning. And so we wanted to know whether or not the facilities had a plan for staff absenteeism, if they talked with their staff, with their residents to see if they talked with the residents about COVID-19 planning. So what happens if you get sick? What happens if your food delivery or your PT, OT, or your home chore services become ill and they're not able to come to you, or you get sick? Who's your caregiver? And so what we got was about 33% of the staff talked to their residents about a plan. About 35% of the residents had a plan, but almost 80%, 78% of the facilities had some type of plan in place for staff absenteeism. Some of the challenges that we did find was that one, there was one facility that was not aware of how to plan for COVID-19 or other type of outbreaks, pandemics, disasters, or where to begin to find that information. And so it took some time trying to go beyond what the usual resources and education that we are providing to kind of drill it down for that particular facility to ensure that they could take something and run with it. And so what came out of it was ensuring that the educational piece was going through the COVID planning template with this particular facility. And what we also learned too was that at independent living facilities, planning was all at the discretion of the resident. So it was up to the resident so whether or not they wanted to develop some type of plan of care for themselves or isolation, quarantine, should they be diagnosed with COVID or their caregiver. Next slide. And so basically, the last part of this pilot project was about case finding, and case finding was to identify those where the gaps were large. There seemed to have been no implementation of any of the recommendations that were going out. And the wonderful part about it was that there was no case finding. There was honest efforts on implementing the recommendations for preventing the acquisition and spread of the virus. What we also did was we asked those facilities, do you want us to share the information, or can we send you additional information that you can use, or the links so that they have, it was twofold. One, resources that they could use, and number two, to ensure that they had the most updated information and that they were not using versions from February that were updated in April. And so 52% of the facilities contacted actually provided us with an email or an address to send those the resources and part of the education that we provided to them via telephone. And usually, sorry, I should have put this in the background. Public health nurses, we usually do face-to-face. This is not something that we usually conduct via telephone. We would go to homes and have these discussions, but because of COVID-19, um, we did this via telephone. But we were willing to go out if we did that case finding to do that face to face. And so, of all of this, what happened basically, our recommendations was to extend the survey activities to all of Oahu public health nursing sections. and then sharing it with our district health offices through the Department of Health in our other counties to use at their discretion. Next slide, please. And so our pilot project expansion, we expanded it, I think it was the beginning of the ending of the second week in April, and we expanded it for the island of Oahu. Currently, we have 98 surveys completed, and that was as of Monday, this past Monday. 75% of them were arch homes. Number of residents, 1,574. Looking at the data on the pilot project expansion, screening of new residents, there was an increase from the 22% for the pilot project to 43% of the facilities screening new residents or screening visitors. The social distancing, as I went through the numbers, we actually saw a decrease in percentages for most categories. As far as to reasons why right now, I was not able to actually look at the data to analyze that, but there were decreases in percentages for most of the social distancing categories. For infection control, the happy part, the good part is that there were no significant changes as far as percentages as to the practices for infection control. But there was also an increase from 35 to 54% of the residents that have plans now. And so that is what had occurred with our actual pilot project expansion. And so part of, I think, Dr. Wen, what we discussed was the education sources and how we provided that education. It was rather difficult doing it via telephone with our care home operators and our facility managers, operations people. It was sharing and doing follow-up phone calls on did you get the materials. And so we tried to keep it to what was easily accessible to our homes and operators. So a lot of the material came from Center for Disease Control and Prevention. We treated each of the facilities as if it was a home and not a facility, because the independent living facilities, they all live in individual units, as do arch homes. They're all individual units. The domiciliary homes, they're all bedroom types. So we're like, yeah, best to go with the home. And so we stuck to what was going on in the home. And then basic things, hand hygiene, cover cough, infection control. Go ahead.
Send it, put the next slide.
Okay. Oh, sorry. Sorry. We pulled off links and information from Hawaii Department of Health because some of the links were changing. We had to consistently update some of the things, the links. So we decided to just have someone regularly check those links, and we pulled off the information which we PDF'd, and we were able to attach those in emails. So the COVID-19 home care guide, what to do if you have been tested for COVID-19. And one of the things that we found, and I forgot to mention, was that none of the residents actually one displayed symptoms, but nothing came out of it. They weren't tested according to the operator, the care home operator. For the most part, we were good with people showing signs and not showing signs and symptoms within the care homes. So back to the Department of Health, what we did was we used those resources there, what to do if you've been tested, what to do if you test positive, because we did receive those questions as to, well, if we get tested, are we supposed to stay home? Do we have to wait? And so we tried to provide them the most up-to-date information or education on what to do, and also linking them back to their primary care providers to have those questions answered if they get into, if they start displaying those symptoms. And so that was a gap that we also found. And then what we did was also use the Environmental Protection Agency EPA disinfectant list to ensure that they were using the right products to be able to disinfect their surfaces and more commonly used areas. So a lot of this was via telephone, and all of it, in fact, was via telephone. And then some follow-up phone calls to go through the materials or resources that were sent to them to answer the question and provide any additional information that or education to address gaps once they received the information. Justin and Sherry, if you folks can add to the educational pieces that may be available for um, our residential care homes.
Okay, great. Thanks so much, Gloria.
Yeah.
Anyway, I'm just so proud of these guys there, Glenn and Gloria, for being so forward thinking and thinking about this population and doing the study and really revealing all the gaps. And so I'm just gonna let
Ada,
Glenn,
Ada, this is Glenn Wasserman.
Yeah.
Just want to add, that was an excellent job, Gloria. Um, let me give you some more context. So when we were preparing this with the National Guard, the idea was to provide, information to vulnerable congregate settings, particularly the ones that Gloria was describing. Um, this is a brand new area for public health nursing. So with COVID-19, we had never had a situation like this. So we wanted to collect the data to be able to understand, where were the risks, what were the gaps, to continue to improve and expand on. As Gloria just described, it's now expanded to the rest of Oahu and being offered to the neighbor islands. Um, the in this, during this process, we had vetted this with OCA and with developmental disabilities to make sure that we didn't compromise or make our roles difficult, because, OCA is more regulatory and we were providing information. But as this has evolved and we've linked with Katie Cook and others, it seems like there are expanded roles and opportunities by working together, which I think has made this exceptional. So I think this forum for working together has been and will be extremely useful.
great. Now, I think we had Sherry Shamos Eng from KCC. She provides this education program for care home operators, education of care home operators there. I think she texted me, she said she couldn't join us, but maybe Justin, I know you've been in touch with her. Maybe you could share a little bit about it.
Yeah, sure. Thank you, Dr. Nguyen. For those of you who don't know me, I'm Justin Lamb. I'm the section supervisor with the Office of Healthcare Assurance State Licensing Section. And we license a variety of facilities and most of the ones that Gloria was referring to in her presentation. So just to touch on kind of what Sherry does as far as education and what we do. Sorry, Gloria, you have to hear this whole spiel from me again because we already talked yesterday. But anyway, part of the ARCH program is, when ARCH potential licensees want to apply, we send them to what's called ARCH modules. Now, the ARCH modules are offered at some of the community colleges, including Kapiolani Community College, where Sherry teaches, Leeward Community College, and Kauai Community College right now. However, Sherry's program is probably the most comprehensive, and I'm sure most of you guys know there is no standardization between the community colleges. So that's something that OCA is trying to work on and make sure that we do have standardization. So that's a long process to try and get that going. But anyway, so those the courses that Sherry teaches, that's only for applicants before they start opening their ARCH home. And then that's usually about 6 months to a year before they would actually be licensed anyway. After that, Sherry usually doesn't have any contact with them unless they need to retake the modules, which usually doesn't happen. Other education that we do with our licensed ARCHs usually is in the form of newsletters, and then they also are required to have continuing education units. So for some of our homes, it's 6 hours per year of continuing education, and then others it's 12 for all of the staff. It depends on the license of the facility. And then so some of the things that we're looking at, and I spoke with Gloria about this yesterday, was right now we're currently doing COVID-related newsletters to our arches and the CCFFHs. Unfortunately, the CCFFH program is very, we have email contacts for all of the operators, but for the ARCH program, we only have about 1/4 of the emails. That's something that I'm trying to work on, and we're trying to communicate more electronically. Some of the ARCH operators have been resistant to that, unfortunately, but I think with the current situation, it's something that we're really going to try and push for. So far in March, we issued a newsletter giving them guidance, and in April, we issued another newsletter. And then I'm preparing another newsletter, most recently, based off of the governor's 7th proclamation yesterday, just so that way we can kind of clarify that, now is not the time to ease up as far as like, what we're doing in the care homes. They still need to be vigilant, and they still need to practice good infection control and social distancing. So that's going to be going out shortly, probably towards the end of this week or early next week for that one. But some of the things I was talking with Gloria about yesterday was, possibly doing a mail out to each one of our licensed facilities. That way, everyone can be sure that they get proper guidance, or to gather the missing emails for the ARCH facilities that we don't have, which would be a lot of legwork on our end because there's around 280 facilities that we don't have contact emails for. Another option was, I believe it was Dr. Wasserman's initial idea was to go door to door, and hand out information as well as be able to answer questions. But I believe that was through PHN and Hawaii Air National Guard only. I'm not sure how much OCA could be involved. I'd have to get Keith Ridley, my chief's permission to have my staff do that. And also one of the other options too was to have Sherry do a certain, like an online class specific for COVID. And I spoke with her yesterday, and she said she'd be willing to, put something together relatively quickly that could be done within the next few weeks. It could be hosted online, and it would not only go over COVID response, generalized pandemic response, but also like a refresher course on basic infection control that, some of our operators that have been licensed for like 20, 30 years, they last did the ARCH modules and worked as a nurse aide in the hospital like 30 years ago or 40 years ago. So it's kind of, a refresher course would be good for them as far as, donning and doffing of gloves and gowns and masks and that sort of thing.
Great. Yeah. So I was just really excited to hear that, everybody can pull together, and now that we know the gaps in the care, we can, gaps in the education, we can sort of work together, get all the contacts, in multiple dissemination venues, with door-to-door mailings, online classes, and just really try to fill those gaps. And I think that's kind of what we, when I was talking with Glenn about the different phases here. So this is sort of this phase 1, which is primary prevention. I know everybody's thinking about, oh yeah, what about the testing part and all the, well, we haven't even gotten past phase 1, which is really basic stuff. But I think, I've just been encouraged to hear that this is beginning. And so if anybody out there knows any care home operators, we need to get them all pointed in this direction to sort of get the basics going. And whatever contact information, whatever modules and things that you put together, feel free, we can post it on our website as well. And then we can, have everybody sort of advertise that way, advertise through multiple venues. I wanted to mention a little bit, I know, okay, so the question is about testing, right? So we thought about this a little bit too. What is the strategy? Who are the places where we can go to? And so we started hunting this down as well with Katie Cook. We've been in and also with Dr. Yazawa. Dr. Yazawa, are you around? I'm looking over here. I think you are someplace. Anyways,
yeah, I am.
Okay, yeah. So Dr. Yazawa put together this I don't know, contact list or strategies for where can care homes get COVID testing if they have symptomatic patients and they call their PCP and the PCP decides that testing should be done. Where can this be done? And so there are a number of different options that we have been trying to pull together out there. I don't know, Al, do you want to talk about that a little bit?
Yeah. So for Oahu, there are a lot of testing options. On the neighbor islands, a little bit more limited. I think the Queen's COVID hotline has been a really good source where I've had some arches and foster homes call, and they do a sort of a televisit with a case manager who then decides whether COVID testing is necessary or not. One person I referred to spoke to an APRN on that line and was told to send a patient to the emergency room, which they did. Otherwise, they have the ability to send a nurse to the home to do the COVID testing. And of course, Queens and HPH both have a house call or home visit program. They're somewhat limited to the folks that they service. And the swab teams that we talk about with the Hawaii National Guard are an option that is and has been stood up on Oahu with the Department of Health. So that's also been used, I heard, in a couple of places over the past week. So a number of places I think that we can assist with COVID testing if it's necessary.
Yeah, this is Katie. I'll jump in on that too on the swab teams. These have been stood up on Oahu through the partnership with the National Guard, so we're really thankful for that. And these would be situations where there's a person under investigation or a suspected COVID case in a facility like this, and if the person is not able to get to a testing facility, we can activate the swab team and go test. So it sounds similar to the Queen's program. There's a few options out there, which is great. If someone's really out of options, they can call us, and the process is really similar to how it would normally be for just reporting any other PUI or suspect COVID case, which is calling our disease reporting line, which is 586-4586. And then through the course of that PUI reporting conversation, if it's apparent that there's no testing option, we can deploy the National Guard swab team to basically any setting where it's needed. So this is for Oahu. Kauai, the district health offices, I think, are setting up their own things. I think Kauai does have something up and running. I'm not sure about Maui and Hawaii Island at this time. How fast do you get results? I see it in the test box. For the Hawaii Department of Health swab team testing, right now we're pretty low incidence. I think it would be a pretty quick turnaround time. It depends on a lot of things, how fast the team can get deployed and then how fast they can get it to the state lab. Generally speaking, if the specimen is at the state lab by 11 a.m. that day, we can get it run same day. If not, it might have to wait till the next day.
Okay.
I'm not sure about the Queens and other testing processes.
Yeah. Okay. So I'm just looking at the list that Dr. Izawa put together here for Kauai. So a couple of care home agencies like Ohana Care Home, they're actually able to assist with going out and doing swabs. And the DOH swab team and Hawaii National Guard on Kauai is also available as well. And for Maui, a couple of home health agencies are willing to do it, but I think as of this date, they're actually doing training and awaiting PPE and not quite ready, but they are looking to do that. Those are like the Home Health Agency of Care Resources and Vaiata, but not quite there yet, but working towards it. Same thing with Molokai, also working towards that. And the DOH swab team also available on Molokai as needed, and as well as Lanai. For Kona, same thing, the DOH swab team and care resources pending. And for Hilo, actually the same thing as well. So a little bit delayed, but hopefully these things will be up and ready very soon. And I'm really glad we do have a quiet lull right now. Cross our fingers, and we will have enough time to get this all stood up in time for that if in the event we need them. Okay, what question here? Any idea what the specificity of the swab testing is? Katie?
Gosh, I'm really sorry. I don't know the numbers off the top of my head. I have to look and see if there's been any recent new numbers. Someone else might know on the call, though. Someone else might know better than me.
Sorry, the specificity of the PCR test, this is Dan Saltman, sorry. The specificity of the PCR test for antigen testing, this is whether the virus is present or not, is very high, but it's got, so if it's a positive, it's very high. So if it's a positive test, you can be pretty sure there's virus there. The problem is that if it's a negative test, you can't be sure that there's not a virus there. So that has to do with the other side of the coin. The sensitivity is not great, but the specificity is very high. It's a PCR test. If it doesn't find that virus fragment in order to amplify it and then test for it, then you don't see anything. So a positive test means that the virus was present. It's something like 90, 99, 98, 99. That part of the test is very good.
Okay. Anything about DOH or labs building testing capacity among the arches? Is that providing tests and training to use? My understanding, these are people's homes, and the staff there are not like nursing homes, and even assisted living is not like that either. There's no nurses who can actually do the swabs, and that's why we've had to try to figure out where what are the venues we can go ask to see who can come to the home to do the swabs if they cannot, and that's why we had to sort of do a lot of the legwork. To sort of close that part of the loop. So appreciate that. And I think that probably this part of the education, once we have all the resources out, I think that's probably going to be something that the educators can also share. Justin Lamb and Gloria Washman, all those guys will be able to share widely among their care home operators in the event that they have suspicious symptoms. They'll know exactly who to call and they won't be fumbling around. Yeah. And of course, once they get tests and depending on the results, DOH will be there at their door, probably doing contact tracing and figuring out how to safely quarantine and isolate the folks there. So that part, the expertise will be coming to their door. Okay, any other questions or concerns about care homes? Any care home operators actually on the line? I'd welcome you to, open up your lines and ask us questions. Are they making exceptions for testing when someone doesn't meet criteria in order to just address caregiver concerns for new placements or transfers?
I can speak from DOH perspective, I guess, or at least our disease outbreak control division perspective. I shouldn't speak for OCA, but for our testing at the state lab, we're generally not planning on using our state resources for testing for anything related to clearance or transfers or things like this. We're endorsing generally. There might be a few exceptions, I suppose, but the symptom and time-based criteria for clearance.
So aloha, my name is Winette Gaylord. I'm a care home operator. I just want to interject on behalf of care homes. The flow chart that Dr. Yazawa has created is very beneficial. I believe that should go out in the packet of information that DOH OCA sends out to the care homes.
Okay, so actually, let me just, I didn't put it up here because it's sort of in draft form, but I'm going to put it up, okay? And let's see what people think about it. I'm going to, John, can I share my screen?
Yes, go ahead.
Okay, I think it's this one. Yeah, let's see. Is this it? Hold on. Oh yeah, I have to press share. Okay. Can you see it? Am I sharing the right screen?
That is correct. I believe that's the one that he had forwarded to me.
Oh, okay. Yeah. Yeah. So this one, actually, this was just something we just sort of, you can tell us if you think this is a good workflow, you know, where if the patient becomes symptomatic, the caregiver should call the primary care doctor, who decides if or not they should get a test. And if they should, you know, make sure the goals of care are consistent, and then start immediately to isolate them, and then notify somebody, which we're considering probably case manager. I think most care homes have a case manager or something like that. And then that case manager will assist in coordinating the COVID testing, which would be one of these several options, right? Either the hospital or health system like Queens or Straub or Kaiser or whatever health system they happen to be in. Some home health agencies may be, like we were talking about, like Bayada or Care Resource. Hawaii National Guard is an option as well. And of course, the very last resource, which we really don't want to do, is just, you know, go to the ER. But that will require the provider to transport this patient who is suspicious for having COVID and risk exposing other people in the process. And then sending the test to whichever lab does it, is designated to do it. And then that kind of circles back around to DOH to assist the care home with their precautions and their cohorting and contact tracing, and then assist them further with figuring out if their caregivers are at risk for exposure and all that sort of stuff. Is this something that that works that seems to be able to work for most caregivers? I'm going to invite Curtis Toma to comment a little bit, because I think he works a lot with this population here, and see what you have any comments on this? Is he on? I thought he was. Okay. All right, unfortunately, I don't see Dr. Toma on here, but okay, so anyway, we've been in touch with him as well. He's with the MedQuest division, and we've been talking about perhaps also involving the payers, service coordinators or case managers or things like that in assisting care homes, as well, as these people already have existing relationships. So so yeah, this is sort of the draft form. If people are, I'm ready for any comments or tweaks or other things that would make this more helpful. Any other care home operators? That I'd love to hear from you guys.
I think it's great. I would love to hear from the care home operators as well for that box kind of in the middle on the top, immediate isolation with contact and droplet precautions, and if they feel ready to implement that at any time, or if this is something that maybe they need a little bit more support with.
I'm going to go ahead and just repeat myself as far as what I had said earlier, as when Department of Health goes ahead and sends out whatever information they are for guidance to care homes, if they can go ahead and send instead of the draft version, maybe if you folks finalize this. One thing I need to interject is not all care homes, as far as the residents, have case managers.
Right.
So where it says to contact the case manager, care home level people are not mandated to have case managers. So maybe that also needs to be included in this flow chart.
Mm-hmm. Who would be the best person to contact, you think?
You see, what we normally do is go to the MD directly, and the MD will go ahead and make the decision as far as what to do.
Okay. Okay.
Yeah, I agree with Juanette. As part of the the arch homes, only the expanded or the skilled nursing level of care require case managers. And all of our community care foster family home residents all have case managers too. But the non-expanded arch residents do not. And it's not a requirement.
Okay.
So yeah, I think we need to, I agree with one that I think we need to put maybe PCP or something, another in there.
Okay.
Because they don't necessarily have case managers.
Okay. Sounds good. Okay.
This algorithm, I'm looking at the bottom left-hand corner. It says if CG at low risk. So the CDC interim guidance also suggests that the individual should wear a face mask during that 14-day period.
Mm-hmm.
So I don't know if they're already wearing it and that's not why it's not included, but just something to add for consideration.
Okay. Yes, of course. Yes. I mean, all of them, everybody should be wearing a face mask already. Okay, great. All right. Any other thoughts or comments or any other ways I just want to hear any from care home operators, any other ways we can be helpful or useful in helping you prepare?
You know, I just want to send out special thanks to Dr. Yazawa for inviting me into this session today. If without his notification, or Audrey Suga Nakagawa from AARP, I wouldn't have known about this. So thank you so much.
You know, spread this far and wide as to as many care homes as you can. We need everybody to know because we're all in one family here. Okay. All right. So let me just take a look. Any other? Oh, there's plenty of phone numbers here who have not identified themselves. Does anybody want to unmute yourselves and just let us know your name so we can take your attendance? That would be fantastic.
Hello, everyone. This is Melissa Sarahina, and I'm a public health nurse from the Leeward Oahu Nursing Office. Thank you.
Thank you.
Dr. Sloan here, if you don't have me already.
Great. Anybody else? There are plenty of phone numbers here. Okay, great. And if you guys have any other comments and you want other topics in the series, please write into the box, in the chat box. So we really want to hear from you.
And I'll just say thanks again to Dr. Wasserman and Gloria and their team for doing this great work. And I'm glad that they were able to share it today.
Yeah, I'm just really proud of everybody coming together and working together across all the aisles and all the agencies. You know, I think usually we think, you know, government agencies that they don't, you know, too much bureaucracy, but these guys have all come together, and it's really fantastic example of collaboration. Okay, so before we close, I just want to say that in order to get your CME or CEs or certificates of attendance, you need to complete the online evaluation form and the link that's on our chat box, and include any comments or ideas for future programs. And encourage you to tune in. Next Monday is our next session, and we're going to do planning a COVID unit, practical tips. And then after that, on next Wednesday, we're going to have COVID readiness in the assisted living facility. So we are trying to cover all the bases. So invite all your friends, and we'll see you next week. Thank you.
Thanks, Aida.
Yeah, thank you.
you.
Thank you.
Thank you.